predict the risk fracture of the by the used in the frac tool. This is a very simple, quick, non-invasive procedure, has a good procedure with acceptable accuracy, no anesthesia is required, and good thing is the X-ray exposure is very less to the tune of 1/10 of the X-ray chest, and no residual radiation is there in the body. But this is not the perfect scan because this projects only the 2D picture of a 3D structure, and this is affected by the bone size also. And this is not accurate if there is a previous spinal surgery, there is already vertebral compression fracture, there is osteoarthritis, but in these cases, quantitative CT scan will be more professional. This central DEXA in elderly patients where there is a aortic calcification or there is a soft tissue calcification, this scan is again distorted. It's not a very good method to note the changes in the treatment during the treatment. So we can use this DEXA for the peripheral bones also, like the distal radius and the calcaneum, and this can be used for the vertebral fragility fracture, but predictive value of the vertebrability is quite low as compared to the central DEXA. Radius peripheral DEXA in conjunction with the clinical risk factors that can be used for a strong negative predictive value. If the things are absolutely normal, we need not to go for any further test in these type of patients. But this DEXA do have the contraindications also, that if there is a fracture deformity or degenerative changes at the site of the DEXA, this cannot be used. If patient has a radiopaque implant or barium presence or recent administration of radionuclides, then cannot be used. Patient cannot remain motionless during the period of the scan, or patient cannot straighten herself or himself, or cannot rotate the thigh, then we cannot use it. This software doesn't work very nicely in markedly obese patient and extremely low BMD patient. So but this can be used by slowing down the scan speed. Then we come to the next, quantitative computed tomography. This, I will not go into much details. This is a better sensitivity modality as compared to the DEXA because it can predict the slight changes during the treatment of the various modalities, and the structures in DEXA which are contributing to the DEXA scan, they should not contribute. We can exclude by this method. This has definitely disadvantage as compared to the DEXA because of the very high cost, high radiations, and poor procedure. But if we apply the WHO criteria on this, that to osteoporosis criteria, we can diagnose the osteoporosis earlier. And in future, even peripheral CT can be done with a small, portable, and less expensive machine rather than the whole body scan. Then quantitative ultrasonography. That is, they are using the ultrasound as a modality, and this is used as a screening tool for the osteoporosis to assess the BMD with the elasticity and the microarchitecture. Currently, this is performed only on the peripheral sites, that is the calcaneum. We are doing the calcaneum, and then patella and finger and tibia can be used. Here also it is expressed as the T and Z score, but WHO criteria we cannot apply on this. Advantages, definitely no ionization, less expensive, it is a portable. Disadvantages that WHO criteria, there is no calibration of the results, and ISD does not recommend that to predict the fragility fracture. And this heel ultrasound with the clinical risk factor again has a high negative predictive value. This is the machine used for for this, and this is how the report is coming. And in PIMS, we are conducting a 1 day per month, the camp, where the BMT is assessed of every person free of cost. So anybody who wants can refer the patient on first Monday of every month. MRI. Definitely it is a better for the images to have the cortical and trabecular both, but advantage is that it is non-invasive, does not require ionization, but MRI based BMD is a good promising tool for the osteoporosis treatment. But International Society does not recommend its use to diagnose, predict risk, fracture risk, and to monitor the treatment. But in future, this can replace the bone biopsy in the absence of clinical, biochemical, and imaging. So, just to high resolution, again, that is again for peripheral sites only. Multi-detector CT, again it is a for the better analysis of the hip fracture. Radiogranulometry, this is just a simplest method for the quantitative. Then photodensitometry, where in one film you expose the bone as well as the aluminum wedge and compare the density. Neutron activation analysis, again this is a less precision and less accuracy. We are not using routinely for the research purposes only. Crompton scattering, again it is a research tool. I am not going into single energy photon absorptiometry and dual energy photon absorptiometry, that is for the mineral content, again not routinely used and only used in a specific cases. Now comes the biochemical markers. This has already been covered by the orthopedician in the panel, that we get it done in the serum and the urine for the during the treatment, whether the treatment is effective or not. And various markers are for the bone formation, that is PICP and PINP, and the bone resorption markers, that is the TRAP, PYD, PD, NTX and CTX. Then with this, then we come to the assessment, why we want the assessment of the fracture risk. There is nothing to say that it is definitely important, because it is said that with just one hip fracture, that means it is a sort of a death sentence for that person. For this, FRAX model is used, which was developed by WHO in 2008, which was a web-based algorithm program based on the predicts the probability of the major fracture event based on the meta-analysis of the population-based cohort of the various countries, in which we put in the incidence of the hip fracture, BMD of the femur, clinical risk factors which are independent of the BMD, and it is country specific. This is how it is done. This is how we fill up in India, in which all the parameters we fill up, and what we get is the 10-year probability of the major osteoporotic fracture in the hip, wrist and the vertebra. It also facilitates the treatment recommendations in the population at the high risk and reassurance in the population which is at the low risk. This helps us in making the informed decisions based on the multiple scientifically validated risk factors rather than just the BMD values. This can be used with or without the input of the BMD. Newly, just in March 2016, FRAX model for the Kuwait has been launched. With this, the countries who are following the FRAX model that goes down to 58 with 63 models. And those countries, as they are country specific, those don't have their own model. They can choose a representative surrogate country. Still advancement is going on, just to make it not just online, make it offline also, and it is being read in the local languages also, rather than in English only. greatest limitation of this is that only very few limb clinicians are using it. More we use, more we can improve on it too. So, just to summarize, DEXA is a reliable method for BMD data measurement, and FRAX is an important tool to predict the fracture risk assessment, but still, FRAX model cannot replace the clinical judgment of a clinician. Thank you so much.
Thank you, ma'am. That was an extensive coverage of almost like an orthopedic surgeon. So, two things which have not been covered by the panel. I just want to say, common question is, what calcium to eat. I've seen a lot of only 450 is available. Plus, it needs gastric juice to get absorbed, which younger people can take easily. So, pregnant women, yes, you can give calcium carbonate, but there are better calciums available. Calcium citrate has got only 21% bioavailability. Calcium citrate malate has got, and other aspartate, orotate and multi combination drugs have got almost up to 80% this thing, say bioavailability. So better to use those in older women. Secondly, they say, just by saying that you take calcium and your bones will become better, it's like saying you take proteins and your muscles will build up without exercising. So we understand how calcium gets into the body. With vitamin D, gets absorbed, goes into the bloodstream, but we don't understand how it's going to the bone. Calcium is a positively charged ion, and when you move, the ligaments and the tendons, they pull on the periosteum of the bone and create a negative charge there, which is the piezoelectric effect. And this negative charge on the bone pulls the calcium from the blood, which gets deposited. So if you don't exercise, then the calcium will not go into the bone. That's what it is. And one more thing quickly, ma'am, I just want to point out, we have already problems enough as a doctor community, and we must screen the content of the experts who come and talk. Nobody can come in such an august gathering of experts. We are talking on one side about gene markers and molecular biology, and somebody cannot just come and activate our seminal vesicles and thyroid and thymus with one posture of yoga. Sorry to say that.
I think they have one part of the lifestyle modification.
Yes,
yes.
But you cannot let them be.
But definitely, I am not talking on behalf of the organizer, but as a yoga, this thing, because they are non-medical persons. They have, because now it is yoga days after the
yoga is good.
Yes.
It makes you die healthier.
Yes.
Does not make you live long.
Yes.
Thank you, madam. Question.
Yes.
Next to straight.
Thank you so much, madam.
Acha.
On lifestyle.
Okay. Thank you, Dr. Pramila. And I request all the
Hello, ma'am. Here.
All the panelists in one go. So Dr. Sushma Chawla, everybody knows she's the senior most gynecologist and a very academic and patient friendly, everybody friendly, colleague friendly, everything friendly, and a beautiful dancer too. So our next is Dr. Hani Chima. She's from KIMS. Then we have Dr. Dan, not from the gynae fraternity, but we welcome him as our good panelist, orthopedic surgeon. And then Tina is our dietitian, and Gaurav Mahajan is our physiotherapist, and Dr. Rana is the senior most person. She's 71 years. I'm disclosing your age, ma'am. And I welcome you as a spiritual therapist in addition to gynecologist. So we start our panel by saying that for every ailment, medication we thought we were beautiful doctors, but now we know that pill is not the answer to everything. So let us make a change and turn the life around. menopausal osteoporosis has already been talked about, but only one emphasis from this slide, that hip fractures are the most serious fracture to have in this osteoporotic woman. So our first case is 51-year-old menopausal woman since 2 years, consults a gynecologist for a routine health checkup. She underwent a health screening panel in which she got her BMD tested, though normal, but she went to the gynecologist. Doctor, tell me what should I do? I want to be as healthy as possible. So she is natural menopause since 2 years, 2 children, no significant past history, but she in the family history she has history of osteoporosis with hip fracture in her mother at the age of 58 years. But her own BMI and BMD both are normal. So my first question is to Dr. Sushma. What is the impact of menopause on bone health? Why we are worried, and how is menopausal osteoporosis different from age-related osteoporosis?
Actually, there is a history of fracture in her mother. So the genetic factor can be there. And since morning we've been talking about the lifestyle modification, the diet and everything, because the estrogen deficiency is going to definitely make a difference in her life. And the bones, they start deteriorating about the perimenopause age. So that is the time when we should tackle with all these things, the lifestyle modification, go ahead with the exercises, and of course the supplements, calcium, vitamin D, and diet and nutrition. And of course,
so menopause is affecting, especially in the first 3 to 5 years before, that is the transition, and 3 to 5 years later. So it's very important, and 1% per year. And whereas age-related osteoporosis sets in at the age of 60, and it's at a slower rate, 0.5% per year. So the second question goes to Dr. Rana. What are the lifestyle measures which will help her to maintain a good bone health? The one which is lifestyle measures for good bone health. Just sum up.
And just now, one of the orthopedician was telling, we can take lot of calcium, we can take lot of vitamin D, still there is no gate to go in. It will only go if you are doing some exercise. Now the person, she or he is prone to osteoporosis, and if we put that person for more exercises, it can create a problem. So we should start lighter exercises like resistance. See, if I am keeping my hand here, I am pushing my head down. I am doing it against resistance. So whenever we are doing any exercise against resistance, we are increasing the strength of our muscles. Start with the neck, then the shoulders. You are keeping your hand here and you are trying to just push it up. So in the beginning you can do that, but then afterwards you can take help of the other people, your partner. He will give you the resistance and then you are pushing it. He is giving the resistance on this side and you are pushing it. Against resistance, our bone becomes more strong. Then, what are the exercises to be done, in what sequence it has to be done?
We take the next question. Next question is just
one point.
Okay, sure.
The thing is, as Dr. Rana said, like progressively we should increase the resistance exercises. But mind you, many of the ladies, they come up to my office, I think to everybody's chamber, and they say we are putting in much efforts, we are doing 50 minutes walking, we are doing this exercises, still we are not having any effect on the weight reduction or anything good amount of things we are not getting. Mind you, when you progressively increase your exercise, it should be 70 to 80% of your functional capacity. That is your level of the exercise. Unless you reach that level, you are not going to get good results.
So my next question is to Mr. Gaurav Mahajan. He's a physiotherapist. What are the different types of exercises for a healthy menopausal woman, not osteoporotic, a healthy woman like ours in this case?
First of all, I welcome you all and thank you, ma'am, for the question. A healthy menopausal woman can do plenty of exercises, but generally we recommend 3 types of exercises for the woman. First is the weight bearing exercises, second is the strengthening or the endurance exercises, And third one is the stretching exercises. First we'll talk about weight bearing exercises. Weight bearing exercises are those in which we use our legs or feet to support the upper part of our body. For example, dancing, jumping, running. Weight bearing exercises will increase our stamina, endurance. Second is stretching exercises. Stretching exercises will help in improving our flexibility, like yoga. Third is the strengthening exercises. Studies have shown that strengthening exercises will increase the bone density and thereby reduces the chance of fractures.
Dr. Dan, would you like to elaborate on this type of exercises for menopausal women orthopedics from the orthopedic point of view?
As you have told,